growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, you're tuned in to The Lionhearted with Dr. Steve Rasner. I think we're in week 6 of these episodes that I've dedicated to navigating through this unbelievable, unprecedented times that we're all going through. I think it's pretty clear that parts of the world, and certainly parts of the United States, are beginning to open up. And you know, that has 2 effects on me. I'm not kidding. It has me a little excited and a little bit scared. I am. Because I don't know what to expect in terms of patient response. Nobody does. And I'm anticipating, and that's the basis of this podcast this week, that there could be some greater hills to climb in having patients accept the most appropriate treatment plan for the reasons they came into your office. So that's what we're going to talk about in this podcast today. I really haven't been that specific in the last several. And this is why, because now my mind is thinking that very soon, and what's that mean very soon? I certainly expect within the next 4 weeks. And I'll be quick to report to you what I am finding on the front lines, because that's what this is for me, for you. I'm trying to navigate through this, guys, just like you are. And you heard me say on all my podcasts, this is one more colleague's opinion, albeit a colleague that's had many challenges that he's overcome with victory in a long career. But this one obviously is completely different on so many levels. I want you to look at me and hear me as someone that's just talking to you on the telephone, for that matter, and trying to say, well, this is what I'm doing. And, you know, I'm certainly no quack, and I certainly have I would like to think, a decent reputation in our industry. But the social media is just on overload for me personally, and very contradictory from one voice to the next. So that you're tuned into me, I'm going to give you what I've got. So let's stay on track. I'm making these a little bit shorter for you on purpose. So what's going to happen? You're going to go back to work. You'll figure out the protocols based on what you're hearing from me and other people in the industry as to what that visually should look like, whether it's somebody in the parking lot, you call in when the room's ready. I think all that's going to change for the better in terms also of the amount of PPEs or feel necessary to wear as the weeks and months go by. I think, honestly, my opinion is that's not going to be as great of a challenge as it seems to us right now. The expense of buying it, the cumbersomeness of donning it, of wearing all that stuff, all of it. So I do think it's going to take quite a while for you to establish a balance of what you're going to recommend to patients once, in fact, they do call your office and come in. You heard me mention last week that we started a week ago for the first time. So that's the first time in 6 weeks for my office that's located in the United States, New Jersey, South Jersey, that we first went to try to schedule patients with a tentative estimation of June 1st. They were patients that had previously were canceled for work they had signed on to do, of which I have not done yet. That's an important point to make to you. But you can't fill up your whole days with that because you have to make room for other things. And so the next line of patients we looked at were the patients that had developed problems and emergencies over the past 6 weeks. To be quite honest with you, most of those were handled by my staff. A lot of them were handled with prescriptions. Others were handled by sending them to the local endodontist who did remain open. So all these patients need to be called, and they need to be seen early on as well. By the way, while I'm talking about it, listen, whatever it takes me to come back, I'm going to do. I've been working for 4 days a week for probably 20 years, certainly 15 years. I'm prepared to do whatever I have to do. If I have to go back 5 days a week, that's what it'll be for a while. I'm not giving this up, and neither should you. If you once loved dentistry, if you pre-pandemic were passionate and loved dentistry and felt you were on your road to a good place, then you need to do whatever you need to do too, just like I'm going to be. I'm 65. I could retire if I want to retire. This is where I'm good. This is my thing. It's my passion, and I'm going to fight for it. And part of that fight means I have to be ready for change when I get back. And I suspect that a lot of that change is going to be apparent at the moment of truth, when either there's emergencies or people, God willing, that come out of hygiene, that need something, or even, I hope, new patients that come to me. What am I going to do? What's my approach? So, over the years, this has been my wheelhouse. It has. I mean, I've gone and lectured all day on case acceptance and treatment planning. And I wrote an article that landed on the cover of Dentistry Today 5 years ago. Treatment planning in a challenged economy. Hey, this is going to be a challenged economy. Absolutely is. And we ride a fine balance because we've been challenged too, and our patients know we've been challenged. So those two words that you hear me always resonate with you, of trust and confidence, will never be on the line more than right now. So let's break it down a little bit. The first thing I want to say to you, and I've said this and I want to be redundant, go back and look or listen to other podcasts, would be that it starts with the first phone call. You better have somebody making those calls that you really trust. And now is the time, before you're back, if you're ever about to make that change, if you think that's necessary, this is that time. You need somebody that is passionate about the success and return of your business as you are. And I have no doubt in my mind I have that person. And it's not because she needs a paycheck or doesn't. I'm fortunate that I have somebody that's got good verbal skills, has good personality that you can feel over the telephone. Do you have that? I know a lot of you do. That's who needs to make that call. Hi, Mrs. Smith. It's Michelle at Dr. Razner's office. We think's good news for you today. We're starting to schedule for the first time since this monster has challenged all of us, or whatever words you want to use. If you'd like, you can write to me. I haven't seen Michelle's script, but Michelle would tell you that I've trained her, or educated her, is a better word, over the years on a myriad of topics regarding the telephone, how to get people to trust you and like you. Do you know how you do that, by the way? You be trustworthy, and you say honest things, and you don't overpromise, but you overdeliver. That's how. I didn't make those things up. Somebody else smarter than me did. But it's easy for me to put on those shoes because I like to be that person. So it starts there. It also starts with, obviously, a review of your new protocols. So nothing is foreign to this patient when they get to your office. It also assumes, my approach to you right now that I'm giving you assumes that your team has been spoken to and that they know the protocols, so that when the patient comes in, they feel safe. They don't feel distracted by, what was that about? This doesn't feel good. You can't have any of that. Now, in my pre-pandemic presentation lectures, I would talk about it takes a patient a tenth of a second to make an opinion about you, even the ones that have come to you. That was studies by Willis and Tadova from Princeton University years ago. And it shouldn't shock you. Patients look at you. You look at people. Don't you? Did you ever see a guy on television speak in a prominence and you saw a missing tooth on that speaker? I have. I've seen missing second premolars or a tooth in the aesthetic zone. And it blows my mind. Well, this is the time to look fresh, clean, and safe. You and the team. If I didn't think that was important, I wouldn't have taken up any time in this podcast to discuss that. Okay, so now they come back and are in your chair. I would think in a huge majority of these cases, they're going to have some kind of issue, a problem that they want you to resolve because they trust you. Maybe it was one of those patients I sent to the endodontist during the pre-opening, and the tooth has cavit on the occlusal table. And what is the treatment? Let's take that one for a minute. We all know that we've been educated to provide some type of coverage for support and strength of teeth that have received endodontic therapy. We also know that there's times, for whatever reason, that there wasn't a lot of tooth structure destroyed from the prior restorations, but the tooth still needed root canal. So the question becomes, what are we going to do with those patients that don't want to make an investment of a crown? I mean, the difference between a core build-up and a crown is $1,000. I can tell you what I'm going to do. I'm going to look at everything I used to look at. And I would suggest you do the same. If you go back and look at my early podcast on treatment planning, you will know that I always tell the patient that I've learned a myriad of subjects in my complete love affair with my profession by taking CE over my whole career. But what I learned the most, that's most relevant to you, Mrs. Green, is called what to do when. And that is my way of telling the patient I'm about to do a comprehensive exam. And maybe we have to do, well, I think you still need to do comprehensive exams. I just don't know what the outcomes are going to be until I get back in the operatories relative to what's happened to patients during this. So let me explain why. What I look at in the 5 areas are the health of their gums and soft tissue. And I'm going to tell you straight up, in the post-pandemic treatment planning, even if they came in for that endo tooth, that is to some degree a line in the sand that I won't cross. I don't think there's an excuse you can make that it's okay for your patient's periodontal issues, and I don't mean marginal gingivitis. I think as a clinician, you have to draw lines in the sand. And mine has always been a optimum periodontal health. Do I always acquire that because I influence my patients to do that? No. But let me come back to that. Let me just move on. So if I see a patient, for example, that does need a crown, or let's say a core on tooth number 30, and for my friends in other countries, I believe we're talking 4-6. And I see it in a sea of inflammation that was never treated or has gotten out of control. Quadrant scaling and root planing and some education is going to be part of that treatment plan. What if I see another molar that's got a 5 surface amalgam on it and is missing a little corner of it as well, but the dentin that I can see underneath it looks clean and hard? We've seen those situations together in your office and in my office. I would recommend it to the patient. I would recommend a crown. And I would, if they said no, that's not a good time for them, either I would provide a core or I'd also be willing to smooth the tooth off temporarily. I'm telling you how I'm going to deal. So when I say that to you, that I'd be willing to smooth that tooth off, that is exactly what I mean when I tell you that that is that one moment of truth. That maybe that won't come up as much as I think it will right this second. But if it does, I would be willing to do that. I would be willing, in some cases, to do a patch filling, maybe at no cost, as a moment of goodwill. And I did a lot of that stuff, as you've heard me say, pre-pandemic. But, this is where we're at right now, as far as I'm concerned. Look, I worked a lifetime to put together a practice where patients accept, in my opinion, comprehensive treatment plans. Patients that came into me with a broken tooth and ended up having a more extensive treatment plan because that was for the long-term good of the patient. And I'm certainly not talking about an aesthetic redo of their old veneers that were ugly but still were functional and were without pathology. I am not talking about that. I'm talking about the patients you and I see every week in the course of a year that have untreated work that they would be better off treating if they could. That's what I'm talking about. So let's go back for a minute to some of the things, and you may want to write to me for this, and you don't have to be specific because I don't remember offering this before. Things that I say when I'm getting resistance, or things that seem to make situations that might be on the border of being awkward trustworthy. Okay, so here's a good example. You're with a patient that came into you and they have a broken tooth. And I think if your heart is in the right place, that you're not speaking of a place of desperateness to try to get a treatment plan, but just because you truly do believe that the patient would make a better decision if they have a comprehensive treatment plan, of which I never use those words. I use the expression of telling them what to do when. I'll say to the patient, of all the things I learned, the thing I value the most for my new patients, or for you, is called what to do when. Like, how do I know the right thing to advise you? And the answer is, I look, and I can do it quickly, at 5 basic areas. I look at the health of your gums. I look at all your teeth. So let me just take that one for a minute for some of the younger dentists, or maybe the D3 or 4 students that might be checking in this week. I mean, you have a patient with a number 30, 4-6, tilted on a mesial incline of, I don't know, a few degrees, not even that much, because tooth number 29 is missing. And that tooth, number 30, needs a root canal. But in that patient's mouth are a number of carious lesions that they're not aware of. That is going to happen to you. Or they need quadrant scaling and root planing. Or they have a tooth, send me a hate mail, in the aesthetic zone that has large decay, but they don't know it, underneath a restoration. And maybe that needs endo. Maybe there's a lesion they don't even know about. Doesn't your patient need to know those other conditions? So I'll say to the patient often, the mouth is unlike any other portion of your body. You don't need me. And I say it just like that. I say, you don't need me to tell you that you have a fever if you have a fever. You don't need me to tell you have a skin rash if you have a skin rash. But dentistry is different. I know everybody thinks, oh my God, a toothache hurts, or pathology always hurts. It doesn't. So when I look at you carefully, I can help you make better decisions. And if you say it like that, which is the truth, obviously, you're battling a patient that might have had work done somewhere else before you that they're not sure they needed. So you really got to put a lot of energy into the earnestness of the wisdom of a complete exam. And then I'll go on to tell them, we're going to look at your missing teeth and decide if that's got anything to do with this. Let's say the patient that's coming to see you post-pandemic has a crown that keeps coming out, had a root canal and a core, post and core. Well, It could be a parafunctional issue. Maybe they have a number of missing teeth, and maybe it's obvious they have parafunction from their wear and their musculature. How could you just do another crown then without addressing it? Maybe the answer would be they want no treatment after you educated them because they can't afford to do what they really should do. Now that's an extreme example because a patient would opt to do a large filling versus a crown if the finances of their life right now prohibited that. But going from a crown that keeps coming out to a full mouth rehab to address that, but you have to give them, I think you have to treatment plan the best case scenario, but be prepared for alternatives, which you keep hearing me telling you about. And maybe the alternative is that you're going to put things on hold that you know they need based on what your lines in the sand are. Where do you draw the line? Are you going to be okay doing, let's say, a large restoration on when you've found, which obviously means, by the way, I'm still taking all the required diagnostics, including full mouth x-ray. I'm not trying to jam my patient. I'm not changing, and I'm not advocating what you do change. What will make you always, in the eyes of your patients and your colleagues, a thorough, responsible doctor. You got to have the proper diagnoses. So, would you be okay restoring a number 30 if another tooth had a very large lesion out of nowhere in the last few months and even had oral manifestations of such a lesion, and the patient might say, I thought something was going on. I mean, where do you draw the line? You have to make that up for yourself, but that's why you need to do a full exam. I think we really need, and please give me feedback at my email, drrasner@aol.com. I really think we can reiterate all kinds of nuances of this moment in our practice when we go back. What decisions are we going to make when we get to the patients in the chair at that moment of truth? You can't just patch everybody together. You can't assume that should be your philosophy, but you will have to have alternatives for patients that require alternatives, as long as you think that action and maybe ignoring other pathology is not putting your patient in greater danger in some sort. Sometimes the answer is going to be quite obvious. Listen, I hope this stuff's helping you guys. I have no other agenda except to be inspired by the emails I get. And, I'm trying to keep it real. So if you have any questions, send them my way too at my name, Dr. Rasner, AOL. Thanks for tuning in to Lionhearted Dentist. See you next week. Hang in there, guys.